Excellent talk, Pragyan.
Thank
Excellent
you.
talk. You actually align with the theme Future for Hepatology. But what do you think? Where are we in terms of bringing it to the clinic? So we are still mining, and we read so many of the omics studies, and their technology of analysis is different. Now they started using AI and
So,
multimodal systems. So what do you think we will ever come to the clinic for the omics data?
so thank you so much for that question, Dr. Sukriti. And I've intentionally avoided the AI part of the talk. Multi-omic studies cannot be possible without some type of a machine learning or statistical approach with a very, very high-end statistical computation. Unfortunately, I feel that the expertise for statistical, even for biostatistics, and for computation and AI in India is very low yet. We don't have that type of expertise yet. So yes, it's still far from the clinics. But I think individual omics can still accomplish a lot. They can help you even with multi-omics. I feel that for our country, it would be good if we combine two omics at a time rather than go for a really a multi-omic strategy, which we will not be able to handle. Another thing is that this is just from my observation that many people design an omic study just because they have access to a mass spec or some kind of a omics platform. That's not a good idea. Omics studies, a lot of focus in omics studies should go on study design and the question you are asking. So that question should warrant an omics study. If you do fruitless omics studies just because you have access to a mass spec, it's not going to give you much. So I feel that a lot of thought has to go into why you want to do it. What is it that there are certain specific questions for which multi-omic studies are gold, but not for all. So that's another very important question. So all omic studies need to be validated. There is no doubt about it. I think nowadays even I'll just finish. So nowadays even basic journals do not accept papers for which have omics data but which don't have validation for the same reason. And I think we should not either.
So, two questions. One, when you do omic study, how do you consent the patient for these? So, we know for genetics you have to take special consent about the implications, and if new information comes up for a particular period of years after we have analyzed, we are supposed to retrace the patient back and then inform them as the information accrues. Now, if I have to do proteomics study in humans, obviously not animal models, how do I consent these patients and what is my responsibility and for how long? That is my first question. And second is, for plasma proteomics, I think we are working in picomolar or sometimes even lower range. So if you take my plasma and test for proteomics, I think the problem here is not only reproducibility, the inter-individual variability, because
Absolutely.
I may be fasting, I may have taken a meal, I may have taken alcohol yesterday, and now my plasma proteomics go for a toss. So what about, besides reproducibility, the inter-individual variability of plasma proteomics? Two questions for you.
So thank you. Those are two very, very good questions. So the first is that in terms of our ethical consideration and consent, it should follow the same way as we do for genetic testing. Because eventually, if something does become a biomarker or some kind of a link to a disease, then it will follow the same thing.
What consent am I taking from the patient? What's my responsibility to the patient? If tomorrow you tell me this proteomics is now associated with this,
so right now,
like genetics, do I have to go back to the patient? And
not until it's established as a marker, as a valid marker.
As per the ethical committee, I think this is where the multi-omics is playing a role. What is happening is people are just going for omics without even focusing on the study design. And most of the data are not giving an accurate result because the study is not planned at the initial stage because you have a fund from somebody and then you think, okay, I have to do some transcriptomics, and then the study suddenly comes up. But the problem is your study design with sample itself is a huge problem. So that is where I mean, be it any field, I think I should respectfully decline that you said there is nothing in hepatology, but
No, there is,
hepatology
but
has
it's still a
been, I
nascent
think,
area.
No, for decades, maybe by now for 20 years, if you can refer Bajaj's paper or Dr. Sanyal's paper, they have been doing metagenomics since like 10,
Yeah,
15
but I
years.
think I agree with you. There are many studies which actually have a lot of, even for proteomics, metabolomics from Matthias Mann's group, proteomics, there's a lot of paper on these single omics, and there are recent studies on, what I'm trying to say is there are recent studies which still need to evolve and actually give us those kind of genetic links which have been already done for other studies.
Can I ask?
Yeah.
So in extension of that, many of these studies are being done on samples that are biobanked.
Right.
So we are actually not contacting the patient here, and once we biobank a sample, what's the implication? What can we do with this patient's tissues or organs, consenting wise?
So I think at the moment, a lot of these omic studies are still exploratory in nature, the way we do it. And it's not really a marker or a very, very high correlation with a particular disease. And until that time, it is just a research question. But if an effort is being made into it being a marker, then I think we need to go the same way as genetic counseling and testing.
I think what Vikram is asking, when you use a human tissue, irrespective of if you have a bank, suppose your LBS, UPB, you have some few lakhs of banks of sera and tissue. Now you use it to predict a disease, to prognosticate a disease, or identify as a biomarker. It is the ethical issues and legal issues are all man-made, Vikram. We have created it. Now, obviously, keeping that in mind, you have to inform these people, or you have to take pre-consent from these people, just like in PGI, Chandigarh. Now, every patient who will get admitted from the beginning, whether he dies or doesn't die, have to provide a consent that in the event of mortality, they will do an autopsy to learn, not medical legal autopsy.
I can always argue against it.
That's correct. You can always argue.
That's not a consent. You either say yes or you take your patient to another hospital.
Yeah.
Consent means you have two options.
You have to inform consent. You are bringing in an informed
Can I
consent.
add something?
It is a choice. You may do an autopsy or you may not do an
Exactly. So you have to provide an informed consent even for biobanking.
That was not a consent. That was, if you have to be admitted in PGI, you had better agree to be autopsy.
That is a different thing. That is done. But even for biobanking, you have to have informed consent.
We always do that. For
That's
biobanking,
right.
yes, we always
Informed consent is
So
a must.
I'll just add something here. I think, and specifically to the question about doing the omic
Vikram, we
studies.
as clinician, even now time is coming. If you remember, as a resident, you used to never take consent for an upper GI endoscopy. Now you have to provide take an informed consent for even an endoscopy, even to touching a patient.
I'll just
So
add
that
something.
is coming, is all changing.
We crossed the time.
Yeah, I
We
understand.
crossed time. We've crossed the time.
Can I
Yes.
just answer your question? So in AIMS, what we do is we actually go, my PhD students, they actually go, they discuss with the patients. Many patients decline to participate in the study, as we have recently faced in fatty liver disease. They are very suspicious about what we are doing with it. They will not give us anything. And but many of the patients also agree, and they come for follow-up. They also ask us, आपको क्या प्रोटीन मिला हमारे ब्लड से, और हम उन्हें बताते हैं हमें
We are
हमें
running
मेटालोथायोनिन
out of
मिला,
time.
देखिए. We have those slides ready,
Yes.
which we show to the we do that have that conversation at AIMS with the patients. That I can tell you.
We're
This is
on
what
the
we do.
throes of personalized medicine. So we are breaking ice, and
Yes.
all these will help us move forward.
Yeah.
Ethical issues will be sorted out in course of time. Both of them have given a very good.
Thank you. Yes, so that is one of the challenges, and that requires, I can sit with you after this and discuss in detail, show you our data and how we do it. It's a long process, and as I said, the actual science begins after you get your omics data set. And I just wanted to answer your second question, which is
There's a
incredibly
symposium,
important.
Massive in Hall 1 from 6 o'clock.
Yeah, I think, so I think something about the lymphatics also, yeah. Because when I got re-educated about the hepatic lymphatics, I found that it's very, very exciting. I just find that lymphoendothelial cells, they are as active or more active than the hepatic sinusoidal cells.
Yes.
And if you find that it has got a major role in the physiology and the pathology, you really believe that in the case of cirrhosis, early part cirrhosis, the lymphatics comes to about 20 to 30 times than more than
30-fold increase.
Yeah, because it has got various expressions. VGF expression, as you have actually told, and then I think it controls the cytokines. It actually handles the immune trafficking. So I think the hepatic lymph is functionally more busy compared to the sinusoids. What do you find the sinusoids?
It's actually the whole
Yeah.
readout of the whole liver.
Yeah.
It will tell you when
Not only just the liver, because this is the immune organ, and the crosstalks with the other immune organs, in fact, is through the lymphatics. So I feel that, if you just get hepatic lymphatic, it's full reach of biomarkers. Because what you find in the hepatic lymphatic, well, you will find quite a lot of things, which are about 2 years ahead when you find the compensated, decompensated cirrhosis liver. So I think that, when I re-educate about this hepatic lymphatics, I got really excited. And I think, thank you very much for taking us through different aspects about that also.
Sir, because from animal it takes us hours because the lymph fluid is so slow. If we cannulate the mesenteric lymph duct, it takes us full day to just get a few microliter of lymph.
Yeah,
So
I think, conceptually thinking, hepatic lymph is something exciting, but then it can be reflected to a certain extent, if you take from the periphery as well. Yeah,
I think
another
that's
point
the
is
most
that
difficult part, getting lymph.
Yeah.
So it's the most difficult part. How do you do that? And how do you assess the lymphatics in a
This
human?
is what I
very
want to
difficult.
ask her,
That's
whether
very
there is
difficult.
any study
Yeah.
where somebody has actually attempted to collect the lymph, either from the liver or
So
from
we are
the
doing this. We'll publish it soon.
Yeah,
But
yeah.
not hepatic. We are concentrating on mesenteric lymph.
Yeah.
But that's what it takes one full day just to get a few microliters from the rat.
That's very interesting. A second point, in fact, you highlight this the lymphoangiogenesis, or the early part of the cirrhosis liver, and because this, in fact, I tell you, it is just not for the liver, but for the tissues outside as well.
Yes.
Yeah, when this lymph VGF is activated, the expression is more.
Yes,
You can find these upregulated expressions elsewhere also.
Yes.
And I find that we find a lot of non-pitting edema in the case of cirrhosis liver. And down south, we find biliary the lymphangitis, something like the cellulitis in the lower limb. So I think whether maybe a clinical correlation with the lymphangiogenosis, etc.,
Sir, you
that
are
also very
absolutely
exciting.
right. It is, since as clinician we have ignored it. And if you see in cirrhosis, before we came, we perpetuated the vasodilatation theory because of nitric oxide theory. I distinctly remember initially there were many studies which is described the lymphatics drains the sinusoids, and there is a sinusoidal hypertension. Sinusoids are usually fenestrated, and there are a lot of perisinusoidal collagens if you see your studies, and there is no way they get drained, and the lymphatic is the only way that it will drain. So if you do initially early days, if you do laparoscopy in early cirrhosis, you will find lymphatic bleps on the liver surface. And that is more prevalent in hepatic venous outflow tract obstruction. And as a young resident, and later on, many of us, premises will remember at institute, your boss, Deep Serene, will also remember. We used to do ourselves laparoscopy in particular patients with venous outflow tract.
Diagnostic laparoscopy.
And the diagnosis of ascites, you will see liver studded with lymphatic dilated vessel looking at white dots. And we know this is not cirrhosis, this is hepatic outflow tract obstruction. You see, the morphologically also that is different. Early part of cirrhosis, now Sunil will agree, many patients have high protein ascites. And in fact, you know, Setu Babu, his dissertation was, not Setu Babu's, it was one of my other fellows. This is, I think, R.K. Jain, who died of COVID pneumonia. His dissertation, that initially we suspect a high protein cirrhotic ascites are because of tuberculosis. And we, at that time, studied over more than 150 patients, and all of them because of increased lymphatics. Later on found out. That is high protein ascite you tend to ignore. And that has been being documented since long. You are right, sir. Hepatic lymphs are very important, and this study is very important. That's right.
Thoracic duct and cisterna chyli are visible on EUS.
So
Maybe,
I was actually making that point. So we can see thoracic duct, at least on radial imaging, very easily. It's very comfortably visible in all. And in cirrhotics, they become so big. But then what is very interesting is, it becomes very big in some cirrhotics, but not in all cirrhotics. And there is a good variability between cirrhotics. We haven't actually looked at it systematically, but we see thoracic duct. In cirrhotics, it is almost always big, but in certain subgroups, it is very big. And this is very well easily seen with a radial scope between the aorta and the spine. With linear, I think it is extremely difficult, but I think we should be able to find the thoracic duct in the same place in a different. So that's very easy for us.
Like portal vein, we can see whether it correlates with
We have been looking
HDPG.
at it. I've been looking at it for long, and what amazes me is the variability in the thoracic duct size, and it's always mostly big in cirrhotics, but in some it is big, in some it is not so big. We can look at it systematically.
So exciting discussion. And sir, there, senior people, thank you very much.
We can have a picture.
Thank you, chairpersons and presenters.